Hi and welcome to another episode of the Mini Battles E-Series by Athens Shoulder Course. My name is Manos Brilakis and I'm the head of the organizing and scientific committee of this course. In less than 2 months, Athens Shoulder Course will take place after 1 year of absence due to the pandemic. In this period, to stay connected with our international friends, we came up with the idea of launching monthly webinars, the Mini Battles E-Series. They are dedicated to shoulder pathology and treatment. So, counting down to the next Athens Shoulder Course, we hope to welcome you and host you live again in person in Athens this May from 4 to 7 of this month. Registration are open. For more information, please visit our website.
So, let me welcome you also. I am Manos Antonogiannakis. I am the chairman of the Athens Shoulder Course. And we established these mini battles every month due to the fact that we had to postpone the Athens Shoulder Course last year. And now, excited again, we are waiting for you in 2 months to the live Athens Shoulder Course. For the moment, we have 4 charismatic orthopedic surgeons that are with us, and we are going to discuss interesting topics of shoulder surgery. So, before we introduce the first speaker, let's see the first question to vote.
So the first question is, which shoulder arthroplasty approach do you use? And the option is tertopectoral approach, subscapularis preserving approach, anteromedial approach, or other approach. Today, this is the episode number 2, counting down to the next Athens Shoulder Course, dedicated to anatomic shoulder arthroplasty for osteoarthritis with a preserved calf. And with us, we have 4 very dear friends and exercise surgeons. Professor Dr. Adrian Błasiak, Shoulder and Upper Limb Department at St. Luke Hospital of Bielsko-Biała in Poland. Professor Dr. Zanda David Werthel from the Hospital Ambroise Paré in Boulogne-Billancourt, France. Professor Dr. Mustafa Karahan, Department of Orthopedics, Mehmet Ali Aydınlan Acıbadem University of Istanbul, Turkey, and Dr. Rick Claro, the head of shoulder unit at CHU Porto, Portugal, and Instituto CUF of Porto, and the president of Portuguese Shoulder and Elbow Society, spoke.
Yes. So, welcome to the mini battle, episode 2, and let's start with the first presentation. Throughout the presentation and throughout the session, you can send the questions, and we would going to have a discussion after the presentation, trying to answer these questions.
Okay. So let the mini battle begin, and we, Adrian, wait for your presentation.
Okay. Can you see my presentation? Because I can't see you.
Yes, perfect.
Yes, we can see it.
Okay. Good evening to everybody. I'm supposed to talk that I always do anatomic shoulder arthroplasty for osteoarthritis with preserved calf. So, what means anatomic shoulder arthroplasty? For me, it's total shoulder arthroplasty, anatomic, of course, or hemiarthroplasty, or eventually resurfacing. So from my point of view, indications are quite obvious. So it's a primary osteoarthritis, a vascular necrosis, rheumatoid arthritis, and post-traumatic arthritis, of course, when the rotator cuff is intact. So, but what about the patient's perspective? So, the patient come to us usually with severely reduced range of motion, persistent pain, usually at night, and loss of strength, and we have to have a consent for the operation, of course. So, nowadays, most of the surgeons do in Europe The reverse prosthesis, the most of them do reverse prosthesis for osteoarthritis and calf arthropathy, following the reverse for fractures, and then the hemi for fractures, and the fourth place is anatomic shoulder total replacement. So indications for hemi are very rare. So usually the very young patients or older, less active, avascular necrosis, post-traumatic sequelae, or some kind of fourth part fractures with complete destruction of the humeral head. The problem is that the survivorship of the hemi ranges from 50 to 80% at medium-term follow-up, so between 5 and 10 years. And the implant failure is usually due to tuberosity resorption, tuberosity in union, and rotator cuff deficiency. And comparing the anatomical versus hemi, so anatomical results in less need for revision surgery, but had a higher complication rate. But we still have to remember that these are different indications for hemi and total anatomic. There's a nice paper from the surgeons from Mayo Clinic. They compared, they assessed his total shoulder replacement. They made it for over 30 years, and the survivorship after 5 years is more than 90%. After 10 years, still 90%, and after 20 years, more than 80%. So these results are really excellent. However, the males are at higher risk of failure, like we see on this slide. The same with the younger than 60 years patients. They also quite often failed, and the best results are with the total shoulder replacement in osteoarthritis, rheumatoid arthritis, and trauma. And what about comparing in literature total anatomic versus reverse? So this study compares these patients, but anatomic for osteoarthritis and reverse for calf arthropathy. At 2 years of follow-up, there were very similar major complications rate and revision surgeries as well, and also clinical outcomes were very similar. Similar paper, but quite much higher amount of patients. Anatomic for osteoarthritis and reverse for calf arthropathy, clinical outcomes were very similar, and the only difference was a slight better improvement in range of motion after anatomic. And this is very curious and an interesting paper, because the authors compared anatomic versus reverse in patients with intact calf. So these were the patients over 70, but still they have intact calf. And of course, more of them were anatomic and less reverse, but in results, there was no difference in complication rate and in clinical outcomes. So that's for me very interesting. These all papers were with 2-year follow-up. What's the problem with anatomic? So these papers show us minimum 8 years follow-up. And we can see that the reoperation and complication rate in anatomic prosthesis is much higher than reverse after mid-term follow-up. Usually complications are calf tear, glenoid loosening, infection, and others. But what's interesting in this paper is that the patient-reported outcomes remain similar between these two groups, despite this reoperation and complication. And what's the problem with anatomic also? So this is a team of Jill Walsh, and they did anatomic in patients younger than 55 years. And after 5 years follow-up, survival was excellent, almost 100%. But after 10 years, almost 40% patients failed, and the glenoid component was a weak point. What about the humeral component? That seems not a problem, because after 20 years, almost 80% of these prostheses are intact, still intact. So the problem and the guilty in the anatomic shoulder replacement is the glenoid component. How about comparing resurfacing hemi or anatomic total shoulder arthroplasty? This is from a paper from Nordic Registry, and the winner is of course anatomical shoulder arthroplasty with the survivorship 96%, following the hemi, and the worst was resurfacing with 85%. And the most important conclusion from the paper is that the young age lowers implant survival rates. That all we know. Another systematic review and meta-analysis comparing anatomic versus hemi. Of course, the winner is anatomic for osteoarthritis. What problems we can face in anatomic shoulder replacement is glenoid deformation, and we can deal with it with eccentric reaming, augmented base plate, or autologous bone grafting. I always try to listen and learn from much more experienced and clever surgeons than I am, so I usually try to use a personal algorithm of Professor Oliver Verbocht from Antwerp. And when I have a retroversion which is correctable to less than 10% and less than 80% of subluxation, eccentric reaming is a good option with the standard anatomical glenoid component. When the retroversion is not correctable to less than 10 degrees, but still we have less than 80% of the posterior subluxation, we can use augmented anatomical glenoid component. In other cases, usually we are forced to do reverse. And this paper also confirms that even in B2 glenoid morphology, according to Walsh, we can use the reverse as well as eccentric reaming, anatomical total shoulder arthroplasty, and these both options are reasonable and the results are comparable. And at the end, I try to show you my own cases, some of them. This is the 33 years old gentleman with primary osteoarthritis. He underwent the CAMP procedure 3 years ago, unfortunately with the progression of osteoarthritis, a typical symptoms. That's the MRI, so the cuff is intact. There's a glenoid deformation and the posterior subluxation. I decided to do anatomical with eccentric reaming, and so far 1 year after the operation he's doing well. The next case is 83 years old lady, primary osteoarthritis, persistent pain, limited range of motion, but still the cuff was intact. So the problem was bilateral. I decided to do anatomical in between 1 year, and now is 4 years after the operations, after the first operation, and she's doing well. The third case is 80 years old gentleman, primary osteoarthritis, and he came to me for the second opinion because he was advised by another surgeon to refuse shoulder replacement. He was curious why, so I performed an MRI. The cuff was intact, not big deformation, special glenoid deformation. So I did anatomical. This is the result after 3 years. So far is good. He's still working, he's still exercising, he makes push-ups, and I hope he will be fine. Not always everything is so nice and happy. So this is almost 60-year-old lady, osteoarthritis, unclear trauma incident in the past, but still the cuff intact. So I decided to perform anatomical, and she came to me after 2 years, and this is unfortunately destabilization with the glenoid and humeral erosion. I tried to prepare her for the reverse. And to conclude, anatomic total shoulder replacement remains the golden standard for treatment of shoulder osteoarthritis in patients with intact rotator cuff. Glenoid loosening remains the major problem. Anatomic shoulder arthroplasty gives better results than hemi and comparable ones to reverse, and the young age of patients significantly lowers the survivorship of anatomical total shoulder arthroplasty. Thank you very much.
The presentation. Before listening to what Jean David has to say, please have a look at our second poll question, which is the following. Which of the following make you to consider using a reverse arthroplasty in the treatment of shoulder osteoarthritis with an intact rotator cuff? And the option is glenoid retroversion, posterior humeral heart subluxation, glenoid bone loss, or all of them. So, JD, you can proceed with your presentation.
Okay. Can you see my screen here? Is it working? Can you hear me?
Yes, perfect.
Yes.
Okay. So I think I totally agree with your algorithm from Olivier Verboot, because you explained very clearly that in many cases you cannot do an anatomic. So I'm going to talk about these cases where reverse shoulder arthroplasty is needed. So you all know that posterior glenoid bone loss is not that infrequent at all, and actually we see that in 40 to 50% of the cases of osteoarthritic patients. It was first described by Neer in 1974, where he noticed that there was some posterior glenoid wear, and that was associated with static posterior subluxation in some patients with osteoarthritis. And then later, of course, it was described by Gilles Valch in 1999 very clearly with his classification that he later improved with the B3 and the D glenoids in 2016. And more recently, Marc-Olivier Gossi provided a very clear 3D analysis of the deformation that we can see in these glenoids. And so the main characteristics, as you just mentioned, is that there is some fair amount of glenoid retroversion, sometimes glenoid bone loss, and also humeral head posterior subluxation. And so, of course, we can use anatomic shoulder arthroplasty, so either hemi or total shoulder arthroplasty for these patients. But it is a great technical challenge because we know that this is associated with high failure rates on the glenoid side. And so there are 4 techniques that have been described to address these problems. The first one is no correction. So you accept the glenoid retroversion and you place the implant in that position. Or you can do eccentric anterior reaming, or you can bone graft posteriorly on the glenoid, or you can use augmented glenoid implants. So if we look at no correction, we know that the maximum we can do with this is 15 degrees. If we do more than 15 degrees, all the biomechanical studies show that there is eccentric glenoid loading, increased posterior stress, early component loosening, and in clinical studies, as soon as you implant the glenoid implant at more than 15 degrees of retroversion, there are early signs of radiographic loosening. There is peg perforation. There can be incomplete seating of the implant. And the most concerning of all these problems is that you don't at all manage the posterior humeral head subluxation. So probably the humeral head subluxation is going to recur, and there's going to lead to early loosening of the implant. So this is not a good solution. Then we can use eccentric anterior reaming, and this has been proven to work. But again, we have this maximum threshold of 15 degrees of retroversion or a bone loss of 8 millimeters. And this can lead also to some problems, because you can, if you only rely on anterior reaming, you're not going to correct sufficiently the retroversion. You have to medialize significantly the joint line, which is not good. You can create pec penetration, because you're going to modify the shape of the glenoid, as we can see quite clearly on these two images. On the right side, you can see that you're going to have to use a smaller glenoid component. It can lead to medial cortex perforation and medial subsidence. And recently, in a review from John Tokish's team, they showed very clearly that the revision rate for this technique is 15.6%, which is not quite acceptable. Then, of course, we can use posterior glenoid bone graft. But the problem is that when we use posterior bone graft with cement and cemented glenoid with polyethylene, well, the graft does not unite. It leads to resorption of the graft, subsidence of the graft, and high rates of glenoid loosening, with revision rates that are at 9.5%, which is, again, too high. If we look at metal back glenoids, they have been tried, but this leads to early polyethylene wear, and it can also lead, of course, to the recurrence of posterior humeral head subluxation, because you're not addressing this problem at all, as you can see on this image on the right, on the metal back glenoid. Well, there is complete recurrence of the posterior dislocation of the shoulder. Now there is a big hope with these augmented glenoids. So initially it was described by Robert Caulfield, and there is this paper published in 2008 with this design of implant where the pegs were parallel to the undersurface, but not to the articular surface of the joint. And this led to high rates of early failure. And we can imagine, now this has been abandoned, but we can imagine that with better designs, such as full wedge, half wedge, or stepped glenoids that have been proposed recently by several companies, well, these allow for less medialization, and they have very promising early outcomes. The problem is that they do not accommodate for big deformations, and we have seen in several clinical studies that a 16 degrees full wedge augmentation led to high failure rates, higher than the rest. And this 16 degrees full wedge augmentation has been removed from the market by the company that proposed it. The stepped augmented glenoid leads to a high risk of central peg osteolysis in patients with moderate to severe B3. So in these patients, it is not recommended. And of course, we're going to correct the joint line, you're going to correct the version, but you're not going to correct the soft tissue balance. And this can lead also to recurrence of the posterior humeral head subluxation. In addition, we know that the greater deformities, even though we can see some cases, as Adrian just showed, of young patients, but the greater the deformity, the bone erosion, the bone loss, typically the greater the age of the patient. And we know that in these older patients, there is significant rotator cuff dysfunction, even without full thickness tears. And so we know that rotator cuff tear, rotator cuff deficiency, at least, even if the tear is not seen on images, but rotator cuff dysfunction can lead to early glenoid component loosening, to shoulder pain, and to early revision surgery. It has also been shown that when we looked at increased fatty infiltration of the supra and infraspinatus with advancing age that can be seen in osteoarthritis, well, it leads to poor clinical results, decreased motion, and lower satisfaction after total shoulder arthroplasty. In addition, there is this paper that was shown in the previous presentation that shows very clearly that in patients between over 70 years old who have an intact cuff and glenohumeral osteoarthritis, there is absolutely no difference in the results between total shoulder and reverse shoulder arthroplasty. So what are the advantages of reverse shoulder arthroplasty in this situation of severe glenoid bone loss and posterior humeral head subluxation? Well, we know that we can position the base plate with some minimal retroversion. We can tolerate even 10 degrees of retroversion, that's possible. We can lateralize easily in case of excessive medialization, either by the design of the implant, which allows metallic lateralization, or by using bone graft, which is going to allow restoration of the joint line, even though this concept of joint line is not as significant with the reverse. It is important to lateralize on the glenoid side, and this can be achieved either by metal or by bone, because we know that under a metallic base plate, there is good incorporation of the bone graft. We also know that because of the strong purchase of the base plate and the screws and the pegs and the keels or whatever you're using, the post, we know that full seating of the glenoid implant is not necessary. So this can allow for easier implantation in this setting. We also know that metallic augments have been proposed with the reverse, and they work. And the problem of this soft tissue imbalance is solved by the semi-constrained design of the reverse, because there are no more translation forces, since the design of the reverse shoulder arthroplasty is constrained. Well, you don't have this recurrence of posterior humeral head subluxation. And so this also prevents the secondary risk of rotator cuff dysfunction, because we know that the reverse does not rely as much on the rotator cuff to function. The only condition you need to have is to have 10 millimeters of central peg or screw in the native bone. And I like to add that it has to have some sort of ingrowth, because you can have, of course, some resorption of the bone graft if you use a bone graft, and you need to have incorporation of the base plate inside the bone, because if you have no incorporation of the base plate and no incorporation of the bone, you're going to have early loosening even with the reverse. So the technique, it depends on the severity of the deformation and the type of implant that is used. But I think what is very important is to use preoperative 3D planning to determine precisely the subluxation, but also the glenoid retroversion and the tilt. It is very important to have appropriate exposure of the glenoid, and it's challenging in these cases where the glenoid is retroverted as we're coming from the front. The glenoid is not looking at us, so we need to do a more lateralized deltopectoral incision if you're going for a deltopectoral approach. And what is very important is to release completely the inferior glenohumeral ligament and the inferior capsule around the humeral neck to be able to dislocate completely posteriorly the humeral head in order to access the posterior, the retroverted glenoid. So what I like to do in case of minor retroversion is to, for example, here on this scapula, you can see there is minor bone loss posteriorly. I like to place my my K-wire, and then I do all the reaming, all the work. I put the base plate, and the base plate, of course, has not full seating because of this posterior bone loss. But I use the bone from the humeral head, and I take some cancellous autograft and I impact it behind the glenoid base plate, and this is very easy. In case of major retroversion, you can either use the angled bio-RSA as described by Pascal Boileau, you can use metallic augments, but what I like to use in case of major deformity is to use the humeral head, because we know that the humeral head has exactly the same convexity that matches the concavity of the deformation, because the deformation has been created by that humeral head. So I like to place my K-wire in the good position, and then I remove the cartilage from the head and position the head in the position that fits the convexity and the concavity of the glenoid bone loss. And then I shape that head in order to have an appropriate lateralization of the joint. And then I place my implant. Often at this stage, I like to fix provisionally the head with small K-wires. And then I do all the reaming, all the preparation of the glenoid as if I was working on a normal standard A glenoid. And this provides very satisfactory results. What I added here is that you really need, if you do use a longer significant graft, you need to use a longer post in order to have at least 10 millimeters of your post or screw inside the native bone. Also, the specificity of these reverse shoulder arthroplasties on an intact cuff is that the goal is to maybe position the greater tuberosity in a more anatomical position than when there is absolutely no cuff. Again, this is very theoretical. Nothing is proven for this, but this is what we believe in. We believe that when the cuff is still intact, we are going to try and minimize the distalization. We like to do some amount of glenoid lateralization, and then we like to play with the humerus in order not to lateralize excessively, in order to reproduce the anatomical position of the greater tuberosity. So in a large patient, you're going to need more lateralization. In a smaller patient, more medialization, in order to be able to repair anatomically the subscapularis. And we like to close the rotator interval. Again, this has not been proven to be useful at all, but we feel happy at least when everything is repaired and looks anatomical when we leave the operating field. The clinical results have been reported first by Gilles Valch's team in this very famous paper by Mizuno with very, very good results. And this has been confirmed by other clinical studies later on. what is important in Gilles Valls' paper is that there was one glenoid component failure, and it is very clear the reason it was because the post length in native bone was insufficient. So I cannot insist enough on this point. Here are some clinical examples. So it was a 77-year-old lady with a glenoid retroversion of 19 degrees, superior tilt of 1 degree, and posterior subluxation of 81%. And you can see that we placed the graft. So you can see this is a 3 months post-op, so there is not yet a fusion of the graft. But you can see that the graft is the shape of the humeral head that we used as the technique that I described previously. And here is, the lady at 3 months post-op. And I'm sorry for my voice. You can see that she has satisfactory external rotation and internal rotation. So it is the right shoulder, and internal rotation is perfectly fine. And I think this is obtained when you have an intact cuff that can be used by the reverse, and especially when you have a significant glenoid lateralization that prevents any impingement between the humerus and the scapula. Here's another. So that was the lady, actually, I think. So that was her CT scan. So it was a B2, as you can see. I don't know why the slide came here. And so I have another clinical example with this lady, who's an 81-year-old lady with 27 degrees of retroversion, as you can see on the planning, 22 degrees of superior inclination. All these patients had intact cuffs. And this is her, and you can see again 3 months. So the graft is here. It's shaped from the humeral head. And so it's the right shoulder in this patient, three months post-op. And again, you can see that when the cuff is intact, the axial rotation so external and internal rotation is not too bad. And a 67-year-old male that we can see here with 75% of posterior humeral subluxation, glenoid retroversion of 21 degrees. And even though the software with the artificial intelligence predicted anatomic in 57% of cases, I was for the 43% of cases, and I decided to do reverse in this patient. And he has a satisfactory result. Again, this is 3 months post-op. And the rotations are not too bad. And you see that for this big patient, I chose a lateralized stem instead of the two ladies before, where I chose a medialized stem because my idea is to match the anatomy of the patient. So the internal rotation is not as good as the two previous ones, but it's not too bad, and I was quite happy with this. Thanks a lot for your attention.
Thank you, Jean, for this show presentation. As time passes, we try to see where we are going to use an anatomic and where we are going to use a reverse arthroplasty, and reverse is gaining all and more acceptance. And so let's see the result of the poll.
In the first question, the 80% used the topectoral approach. And in the second question, all the above, that means the glenoid retroversion, the posterior humeral subluxation, and the glenoid bone loss was indication for a reverse in the with an intact cuff. So, Mustafa, give me your comment. What do you think about all this?
Well, it's very well put. Their own preferences. I have my preferences for these kinds of patients, but at the end of the session, we have to give some advice. My personal preferences. Really, age is very important, and since reverse is something that has come in the recently, I'm really concerned about the revision of reverse cases. So I try to keep it as simple as possible. So age is my primary factor. And we are talking about intact rotator cuff. And I would definitely say that. Let me throw that in and hear what Rui has to say.
And do you have an age limit for the
Biologic age? For example, the patient, I think Adrian showed, 80-year-old patient, he looked like 55 to me, 60 to me, 80-year-old male. So, you know, he's fit and, you know, he looks good. So and also again the Adrian, one of the MRIs he showed, he said that the rotator cuff was intact. I would call that a dysfunctional rotator cuff. So that would increase the age for me, the biology of the patient. So all these factors put together, I see the point that the glenoid is more secure with the reverse. I see that, but on the other hand, when there's defect, reverse is better. But still, age is my number one parameter to decide.
But the paper that Adrian showed, where all the young patients with the reverse, the survivorship is bad, is not a concern for you?
I didn't hear.
I didn't understand.
Adrian, he showed a paper where the survivorship of anatomic shoulder arthroplasty was quite bad for younger patients.
Like I said, it's not a clear-cut issue for me. The revision of the reverse scares me.
Yes.
So
Okay.
I tried.
and your position, Rui, which is your view on this matter?
I agree with Mustafa. I always try to keep it simple. I try to use, like, if I have big erosion, I will try to keep it as simple as I can. We know that the survivorship of the anatomic is not only the glenoid. We know the natural history of the rotator cuff. Eventually, if you live enough, eventually an anatomic prosthesis will need to have a revision for a reverse. So I try to use anatomic as much as I can with a rotator cuff intact. But in specific cases, like the presenters told us, big erosions, asymmetric erosions, even with a intact rotator cuff, we know that sometimes we cannot achieve high survivorship. So eventually, we don't know for sure, but eventually we are treating better young patients with huge erosion with a reverse. Try to avoid 2 stages or 2 surgeries and try to be better, but we don't know. We only know for short-term or mid-term follow-ups. So I do case by case, try to have every possible weapon that I'm available. I use sometimes Emmys with, for example, pyrocarbon, humeral head, and big erosions. I don't have big erosion with like a B2 or a C with a static posterior subluxation. I don't think we can manage the soft tissue properly to use an anatomic and to do well in a short term or a mid term. So case by case.
Okay, this is true. However, even if we all say about anatomic, the current trend is that reverse shoulder arthroplasties are much more than anatomic that performed. This is why this is because they have more indication, or because anatomic is more demanding. Adrian, you saw a slide like this, that the trend is reverse.
Yeah, exactly. Because I think the reverse forgives much more small mistakes. As Jean-David said, you can balance the bone, you can restore the bone, but you can't restore the soft tissue. You in anatomic you play with the soft tissue balance. In reverse, you can play mostly with the deltoid. So it's much more easier to play with deltoid than with the all rotator cuff. So that's the problem, and I think that with time we try to understand in which patient we can put in anatomic and in which definitely not, because it won't work, because it's no compliance for sure, because the bony defects and the bony glenoid erosion. And definitely what Jean-David said, I completely agree. If you have I showed you this paper with B2, and there was a similar outcomes in anatomical and reverse. But definitely in that cases, if there is no very young patients, I would go for reverse. So that's my choice, and I agree with you. I don't have.
Adrian, you should not agree. This is a battle. You should disagree.
Okay. This is difficult to fight with you, but definitely, I don't have a upper limit of the age for the anatomic. So for me, it's the cuff on MRI. It's not age metrical age, but biological age, as Mustafa said. And third, I reassess the cuff intraoperatively. If I have any doubt, I would go for reverse. So because if you have a tear, it's a degenerative cuff tear. So we know that after cuff repairs, we have 30 to even 70 repair tears. So if we try to repair during doing anatomical total shoulder replacement, we can expect repair, so fail.
As the older of us passed from all the stages, from resurfacing, from hemiarthroplasty to anatomic, and then to reverse. We were used to the anatomic, and we know that if we have a good anatomic arthroplasty, we have a very good result. But also we know that it's depending in many factors, especially the amount of deformity, the situation with the rotator cuff. And reverse shoulder arthroplasty is much more forgiving, and also as a semi-constrained prosthesis, it's much more we have most of the time a good result without taking into consideration all these things that we have to take when we do an anatomic. At least in my practice, slowly, I realize that I do most of the time now reverse, quite opposite from what I was doing 10 years ago. And we know, I have the impression now that if we have an intact cuff with a reverse prosthesis, we can expect an equally good result as with an anatomic. And that the idea that with a reverse prosthesis we had better, worse results in rotation, in the rotation of the arm, was due to the fact that we were doing reverse in more difficult situations. I mean,
more difficult situation
in a big glenoid, we do go for a reverse, or in a rotator cuff arthropathy when we don't have cuff, or when we don't have external rotators also. And this makes the results of reverse worse than the results of anatomic in rotation control. At least this is my impression now. And so I think now I would do anatomic to a less deformed arthroplasty, arthritis. Unfortunately, in Greece, people are doing are coming for arthroplasty when the deformity is already advanced. They are not coming early. So with reverse arthroplasty, we found a solution to a problem that before it was not possible to solve, and gave a very bad reputation for shoulder surgery. At least in my experience. I don't know if you agree, Mustafa. Guys, we are older and we passed.
I was thinking of the Mayo Clinic study. The 20-year survival rate is 80% with the old traditional techniques. That's not bad. So, but it must be based on proper patient selection techniques, and the new technology is probably expected to address the remaining 20%. So, John David, I was going to ask your impression about this paper. What do you make of this 20-year survival rate? It's very high, isn't it?
It is very high. It is very high, but it's always difficult when you look at only survival rate, because you don't know if the patient was doing terrible and just was too old or too frail or didn't want to undergo revision also. So that's something we need to have in mind. And when we look at the 10-year survival for reverse, because we don't yet 20 years, but the 10 years in the series from Gilles with old implants, now maybe we can expect more with more modern implants. It's 93% survivorship at 10 years. So I think we know that the anatomic fades at some point. We don't know really yet whether the reverse fails. So I guess we'll see. Maybe we will have bad surprises. But I think what Manos just said is very true. I think we were used to implant reverses in worse patients. And often when I implant reverse in a patient for a perfect indication of a very big cuff tear arthroplasty, the results are disappointing to me because they're not as good as my results with intact cuff. And so I think that reverse with intact cuff is something that is going to grow in the next years.
Yeah.
Adrian,
it will definitely grow. I agree with you. I have nothing against it. It's just my personal. Please.
Okay, Mustafa.
No, but I agree. It is more elegant to implant an anatomic because it's more challenging. It's technically more demanding to correct the version, to manage the soft tissue balance. But then when you think, why am I doing that? Well, the answer is difficult to find, I think. Is it just because I am a shoulder surgeon, so I should do the more complicated stuff? Or is it just, or do I truly believe in it? And I don't believe that the outcome of an anatomic, especially in the 72-year-old patient, is going to be better. I don't think so. So maybe it is more elegant, maybe it is more by the book, by the rules, but I'm not sure it is best for the patient.
Do you think eventually, at long time from now, we will stop doing anatomics?
We are going to do
that's
much
what I would have said a
That's
few
for
years
sure.
ago.
Yeah.
It depends. If we improve glenoid fixation in newer anatomic designs, and maybe we will manage to do that. And maybe better bearing surfaces, maybe the new polyethylenes that we have that are highly reticulated or vitamin E. This maybe is going to change, but now clearly the weak point of the anatomics is the glenoid implant, and so if we improve that, maybe it will change things.
Yeah, in the past, the fixation of the glenosphere was the weak point. So we have a lot of problems with the glenosphere, and now it's better. So I think that's the reason why we have better and better results of reverse, because there is no problem on the stem side like in anatomic, but still the glenoid is a problem, and that's improved with years. So yeah, problem. You are right. Maybe in 10, 15 years, 75 or 80% of our prostheses will be reverse. So it depends.
However, Alexander Landerman in the question group highlight that there is an article from JSCS of last year which shows 100% survival rate of glenoid in anatomic components. However, Adrian, I want to ask you, what mean for you in an 80-year-old patient the preserved calf, and how you evaluate it? You said from the MRI, and you confirmed during the surgery. But my concern is how much confident you have that the calf will be preserved after the implantation of the anatomic in this patient.
Okay, so I will answer you like that. If the guy at the age of 80 have still on MRI the calf, it will survive for sure, because it will survive for 80 years. So probably there is no problem with the calf. There is no problem with degenerative of the calf. We all know that that was a Sach paper about the asymptomatic calf tears. So over 60 years, almost 60% of people have an asymptomatic calf tears, symptomatic or asymptomatic calf tears. So these are people which will have problem with calf, and that guy probably will not. That was the first thing. First reason. Second, I try to assess MRI. Even if I have a small doubt about the calf, but still the function is okay, I will go primary for anatomic, and I reassess the calf during the operation. If I have any doubt, but it is less of my cases, I go for reverse, but usually I go for anatomic.
Okay.
All the problems are not solved. As we have the problem with rotator cuff in anatomic, we have the problem of deltoid deficiency as the years pass with reverse or stress fractures of the acromion. So we don't have answers to everything, but with reverse arthroplasty, what we see is that we have quickly a very good result that it's predictable to most patients. And at least in my experience, comparing it to anatomic and hemiarthroplasty, I was more anxious when I was doing an anatomic about the result than now that I'm doing a reverse. It's much more forgiving, I think, and at least for medium-term results, the results are very promising. And that is, I think, the pressure on us to do more reverse. Theoretically, to do an anatomic is easier. To do a good anatomic, I think, is much more difficult. And this is also a problem.
So about the exposure, I always do delta pectoral. So any of you guys do subscapularis preserving? Can you talk about your experience with it?
I do delta pectoral always, even for reverse and anatomic. I just do a peel off the subscap and bone sutures, and again to the lesser tuberosity. I try to do not change what is working, but I really wonder about your experience in that case, because I know that some of surgeons do anatomic from the delta pectoral and the reverse from the anterolateral or superolateral.
The superolateral.
As I understand, we all do the Doctor approach. Jean-David, what do you believe about the subscap repair in reverse? Which is what's your opinion about this?
For me, it's like when I go to the toilet, I like to keep it as clean as when I arrived, you know. So I close everything, and it was here before I came. I close it when I leave. I like to close the rotator interval, as I told you, because so there are some studies showing that it is better for internal rotation from Philippe Collin. I don't know if it's true or not, but there is a study that says so. There are studies that show that it is better for stability. Again, we don't know if it's that clear, but some studies say so. I feel comfortable when I close the interval, close the subscap, because I have a nice soft tissue environment around my implant, and I feel that it protects the arthroplasty from infection more. Again, this is absolutely not true, I'm sure, but at least when I close the patient, I don't see the implant anymore, and I'm very happy with that. I like to make a sufficiently strong repair so I can have the patient move straight away, and I make sure that the subscap does not limit my external rotation, so I repair the patient with the arm in external rotation, and I repair the subscap. But I don't understand why I would not repair the subscap. Do you not repair the subscap? Some of you?
Well,
I repair.
in anatomic, you have to repair the subscap, but you must be very careful with the repair. I think it's one of the most important steps at the end. And in reverse, if I don't have good external rotators, then I prefer not to repair. And after every repair, I check the stability before the repair, as all we do. But after the repair, I also take the patient through a full range of motion to be certain that it has a good range of motion. And if the suture loosen, I don't retight them in reverse. I leave them as it is. So
if you say when they don't have good external rotators, you mean when you have to do a lepiscopo transfer also?
yes, this is I do sometimes. It depends on how bad is the external rotation. If I have the teres minor, I just don't repair the subscapularis. If we don't have teres minor and have external rotation lat before the repair, then before the arthroplasty, then I do latissimus dorsi transfer with the reverse, and this gives satisfactory external rotation at least. Happily, there are patients that they are not having. They have no external rotators. Usually, they have the teres minor, so they can manage with the lateralization of the implant and I avoid to repair the subscapularis in this situation.
Rui, there's a question from Abdelhamid Misir. If you want to comment on this, how you measure, how you count the functional capacity of the patient and the demands of the patient, how it affects your decision process and your choice.
If I understand, to choose from an anatomic or a reverse, for example, in a whole patient, because
maybe on this, or maybe your implant selection, or what, how it affects your decision.
Usually when I have, I agree with Dr. Mustafa, because sometimes we are dealing with a old patient, 70, 80 years old, but very active, with a good function. And sometimes we are dealing with a younger patient, less than 60 or 65, with a bad cuff or low demanding patient. So most of the time, when I have a patient up higher than 70 years old with not so good cuff, for example, Adrian shows us a case that eventually, okay, it's a good cuff or intact rotator cuff, at the MRI, but for me, eventually I will do a reverse because I feel it's more reproducible. If I do it right, okay, I know the problems I could have, the complications, but if everything goes okay, it's only one surgery. And nowadays, with the new implants, I tried always to lateralize the glenoid, the function, even the static of the shoulder. Um, I don't think I will do an anatomic in an old guy, because with the reverse I can almost have the as a good function as good as an anatomic. So yes, it's something that I analyze, but the cuff, the intact of the cuff, it's demanding.
So regarding a young guy, 40 until 60, with a functional, with a high demand, you go for anatomic, I understand.
Yes, if I can, I will go to an anatomic. I only do EMIs in not post-traumatic or traumatic, in vascular necrosis with a collapse of the head, with a good glenoid, with a stable, with a no retroversion, no erosion of the glenoid. Try to bridge the second procedure as long as I could, or as long as I can. Try to avoid an anatomic because the glenoid is okay. I only do the reverse years and years before. So only in those cases I do an EMI. I don't do resurfacing because, as we published in the last days, resurfacing, the amount of revision is very high. So I think everyone is avoiding resurfacing. EMIs are only for a few cases, and the concern, the debate, the battle, I think it's anatomic or reverse, in this gray area of patients that are not so old, not so dysfunctional, and not so young. I think the battle is in between.
Yes. Antonio Cartucho asks if there are any situations that you consider to use a superior or a superior lateral approach. Is anyone that can?
For me, not. I do always delta pectoral, so I don't have any problem, so I don't change it.
Also.
So there's a question for Milica Velinovic, but I'm sorry, I don't understand the question. Please rephrase it if you want. So I think this is the discussion is coming to the end, and as always, we understand that there is not a battle. There's not. We have same problems, and we have same thoughts about this, and we try to find the solution in the common problems. So this mini battle series have this conclusion in every episode. And I would like to thank every one of you that participate in this fine discussion. And I would like to. I believe that we always met in person the next few months in Athens or in ESCA or in every other. We have to meet each other again after this pandemic.
So we are surgeons, we are shoulder surgeons, we operate, we meet problems, we try to find solutions to these problems, and we are going to discuss a lot of these problems next May in Athens. You are all invited. We are going to discuss about the problems, present our solutions, ask for your solutions, and try to find the best way to solve the problem. Thank you. for your participation, all of you.
Thank you for invitation. Good night to
Thank-
everybody.
Thank
Thank
you
you.
very
And
much.
everybody,
Right.
see you in the next episode in April, dedicated to surgical exposure of reverse shoulder arthroplasty. You can always follow us in Facebook and LinkedIn pages and stay in touch with us. Follow BMed because there are many interesting webinars hosted in this platform in the forthcoming period. And once again, thank you everyone for attending. Good night.
Thank you, guys.
Bye.